Dr. Richard Baverstock is known to many of you, I'm sure. He's a urologist at the Southern Alberta Institute of Urology and also runs the VICIA, Alberta Bladder Centre. He's been here in Calgary since 2004, having done his meds and residency at UBC in 2003, and then a fellowship in male reconstructive surgery, andrology and incontinence in 2004. He's Director of Quality Assurance for the Division of Urology and a representative with the Alberta Medical Association. And in addition to all that, he does quite a bit of teaching. And so I think we're very fortunate to have Richard with us tonight, who's going to speak on post-prostate cancer, therapy for incontinence and surgical management of erectile dysfunction and incontinence. So if you would please help me welcome Dr. Richard Baverstock.
Thank you guys very much. I know I've been doing this for a while, and I was counting. I think this might be my 5th trip to the prostate group. I've been with the various locations. I was talking to Kelly and David about that. And then also recognize a lot of people in the audience, which is often a good thing. Thank you for coming if I've done something to you and it's helped. And also, we're not perfect as surgeons, although some of us think we are, but we're not perfect as surgeons, and so there may even be people here that haven't had the outcome that they wanted. And that's what we're going to go through tonight, kind of the goods and bads. One of the reasons when Kelly reached out to me, actually simultaneously, a bunch of people reached out to me to come and talk. One of them was the Calgary Ostomy Society, where I've talked about this for bladder cancer and the work that we do there. They asked me for an article for September, and then Kelly asked for an article in June, and it all seemed like a great idea. I said yes to everything, and then of course life goes on, and then I was the soccer coach, and so that went on tonight, and I got out of that, and then the fellowship meeting at the Foothills. So all in all, it's a busy life, and I just wanted to thank you guys for having me here. A little bit of a background just in terms of, what is a urologist? And most of you in this room have met a urologist or been part of a urologist practice, even if you ended up, say, at the Tom Baker Cancer Center. So how do you become a urologist, in case you thought about starting this up? You need an undergraduate degree, that's 4 years. Then you need med school, that's 4 years. And then you need residency, which is 5 years in Canada. And then typically to work in Calgary, you're going to have a fellowship that's 1 or 2 years. So that's the fast track. That's as fast as you can get. Usually what that means is the person that you're sitting across from, if they're young, they have $400,000 in debt and they don't have a pension. So don't fault them for wanting to make a bit of money. Somebody like Eric Hyman, who you might know, Dr. Gatto, they have 2 years of fellowship. So another year beyond me. Eric Hyman has a PhD as well. So I'll throw that into the mix. And you've got somebody that trained a very long time to do whatever it is that they're doing in urology. My specialty is incontinence. I don't see anybody in this room whose prostate I took out, but before we had the SAIU, the Institute, I did quite a few radical prostatectomies, and then as the robot came in, we sort of identified in our group, okay, who's doing robotic prostatectomies, who's doing open, and then I migrated into basically this reconstructive work. So if you meet me, it usually means your prostate has either been radiated or been removed. Or you can't pee, or if you've injured your waterworks in some way, and I'm there to help. I also do a lot of work with bladder cancer. And you might think, well, that's not me, but a proportion of people that get radiation may later on get a secondary cancer, and you may meet me in that realm as well. This is a letter I like to share with people. I wish to thank you very much for giving me back a normal life with the surgery for the artificial urinary sphincter, which we're going to talk about it. After the surgery in Calgary on December 2nd, 2010, I activated it, and I'm going to talk about activation of the sphincter. I felt so good following that I didn't think it possible. I do not need to use a pad at all anymore. What a relief after 2 years of using 4 diapers and 4 pads per day. Also the agonizing clamp when I wanted to go out in the evening at all. I know that I'll have an issue with scar tissue. He's talking about a bladder neck contracture, scarring that may occur where the prostate used to be, and we've sewn the bladder to the urethra. I had to get him open, and and make sure that scar tissue stayed open. I did not realize how sensitive the surgery was going to be, as I experienced a lot of soreness around the scrotum. I ice myself twice a day. So he's talking about the post-operative recovery, and I know one of my patients in here struggled with his bowel function after the surgery. So there is a post-op recovery. It's been worth all the pain or discomfort to have such great results. I'd recommend any man who has incontinence problem have this operation. I wish to thank you once more, as living a normal life again is a great reward. So a nice letter, unsolicited, and sent.
Top button for pointer.
Okay, perfect. And that brings me to the next slide, which is help is available. So we're going to talk tonight about why men leak after prostate cancer therapy. And I really open that up to include radical prostatectomy, cryotherapy, radiotherapy, brachytherapy, any HIFU. There are many reasons that people leak, and then there's some combination of many of these therapies that people are getting now. They got a radical, now they get radiation. Surgical treatments we'll talk about, and then we're going to touch on the surgical treatments for erectile dysfunction, which is often something that is not something you'll consider in the first year after life from your prostate cancer therapy. It may be something that we consider down the road. Now, in this organization, as I met David, many of you are down the road from your prostate cancer treatment, so it might be an appropriate thing to think about. And we're just going to talk about that tonight. I was interested to hear, I think David used the word journey, and also the man from University of Calgary talked about the journey. And there is a journey, and you guys have sat through session after session here, month after month, hearing about the journey. Should I get a PSA? What about a biopsy? Should I have treatment? When I first started these sessions at the foothills, I don't think there was an active surveillance group, because in fact when I spoke of active surveillance 10 years ago in our rounds, it was as if I was some type of wild cowboy. And now active surveillance is a well-established part of the prostate cancer journey. Surgery, radiation, what are the risks of each? Including what is the risks of doing nothing, for sure. Cancer's gone, but so are my erections. Will they come back? When will this leakage stop? And I made this slide up to really put it into context. The day of surgery, I wonder what this ride will be like. After surgery, doc says he got it all. The day he realizes he has no erections. The day he realizes he's wet, another dip. And then the day, say, Viagra works for him. And just looking at this journey that many of you have been on, and many significant others have ridden this ride with their partner. So we're going to talk about what makes a man wet. So why, after your prostate cancer surgery, I'll tell you, by people that know what they're doing. They're doing a great job. They're doing a great prostatectomy. And I used to tell people when I did prostate cancer surgery, prostatectomies, that some you would want to film and play during hockey night in Canada because you thought you were that good. And that guy comes back with no erections, and he's leaking. And another one, it felt like you're first. You just couldn't wait to get out of the OR because you just thought, I should quit medicine. And that guy comes back to you and he wants to give you a hug because he's doing so well. And surgery is incredibly humbling that way because it's an unknown. It's an unknown for you guys entering. And even though we've practiced, we've done this many surgeries, we've done these steps again and again, I can't look at a man and say, you are going to be dry and you are going to have erections. And that's the great unknown. Now, truth is, there's things that we do to the prostate that can create problems. Obviously, the active surveillance group may or may not be talking about incontinence because they still have their prostates. Now, it doesn't mean they're not talking about BPH or enlargement of prostate symptoms, urgency, frequency, gotta go pee, because they still have a prostate. So the active surveillance group might talk about the problems they have with peeing. The post-prostatectomy group might be talking about the things that have happened since their prostate was removed, whether it was open or Da Vinci, whether there was a rotor-rooter or green light laser or TURP, radiation, brachy, cryo, HIFU, proton beam, whatever it is, there's not a wrong choice that you've made. And I always think of the man that's sitting in the room, he's angry at the outcome, and he thinks, if I had only chosen X, I wouldn't be here. But as a guy that sees all of you guys, whether you chose open, Da Vinci, radiation, cryo, there is a potential complication of all of those things. And I think dwelling on the what if I had chosen something else is just not healthy. Let's deal with it together and let's move on, because we'll never know what would have happened if you had chosen something else. We do know a few things. You're more likely to leak if you had a bladder problem before surgery, if you were older when you had treatment, if you had had radiation and prostate, just as sort of a combination, if you had had prior TURP, so you had a rotor-rooter maybe, there was prostate cancer in the specimen, and then you chose to have a prostatectomy. That can lead to leakage. Preoperative continence status. Now these are old studies, but obviously you want to go to places that do a lot of prostatectomies, and you want to go to a hospital that does a lot of prostatectomies. Now it's interesting, when I see men who have a terrible time with incontinence after surgery, sometimes it's a complete unknown. It went so well. But sometimes it is the man whose catheter got pulled out on day one accidentally, hooked onto the bed, confused in the night, pulled out his catheter, or he had a leak or scar tissue. So rest assured that at Rocky View we're doing a lot of these, but at the same time, you don't want to be somebody's first. And they might be good at it, but you definitely don't want to be a first. Now, prior problems and procedures put you at more risk, better outcomes at higher volume. That would be the takeaway. Now, in Canada, we don't really compete for patients like an American system where you would put a billboard up on the edge of the highway and you try and attract people. In Canada, you have to get a referral to somebody. And then we've basically edged down the number of guys that are doing prostatectomy. Radiation, likewise, it's a standard center. You can't buy it elsewhere. And so everybody's getting the same thing, but the outcome is not the same with every man. And then here's the question, will I leak after prostatectomy? Well, the first few weeks, leakage is very common. Of course, I don't know in here who's had their prostate removed, but I remember as a medical student with Lorne Sullivan at UBC, and he said to me, go take that man's catheter out. And I was like, okay, he's had a prostatectomy. I took his catheter out and he just started pouring urine out. And I thought, this is terrible. Oh my goodness, what has happened? Now I came to realize that that's quite a normal consequence of removing a catheter, and that is not the rest of life. So the very first few weeks, leakage is common, but it should get better steadily. By 2 to 6 months, leakage should be less common, and about 1 pad per day would be typical at the 6-month mark. After 6 months, we obviously want most men to wear no pads or have a pad in for just in case. Now sometimes in these audiences, people have come to this talk because they are wearing 3, 4, 5 pads a day. And that is probably the man that I want to meet, because I want him to know that it's not just enough to say, there, the cancer's gone. I need a shot at getting his quality of life back. And that's really the business that I'm in, is trying to improve the quality of life. Because I'm actually out of the prostate cancer game. So I don't remove any prostates anymore, so I just see you afterwards if another guy has sent you to me. Because in Canada, I need a referral. But at 1 year, let's call it 1 year, if you are still wearing more pads than you would like and you're wetter than you think you should be, that's an opportunity to say to your urologist, Dean Ruther, to Steve Angelfi, whoever your person is that you're most in contact with, to say, hey, can I see Baverstock? Because he wants to meet me. Male leakage, as bad as it gets. And this is a patient, he actually, like David, where I said, David, what are you doing? 10 years ago you had your treatment. Like, it seems like you could break free, but he's given back, and so is this guy. And this guy feels like he's earned his stripes. He's suffered, but he's given back at the Prostate Cancer Center as a volunteer, and it's amazing. 65 years old, he undergoes a prostatectomy. I'll remember this, I did his prostatectomy, and he was lying on the stretcher out front, and he said, my kids are really nervous. I said, why is that? He said, because my wife died on an operating table last year. And I'm like, whew, that's a good omen going into the OR. Yeah, thank you for that. A little bit of upside down horseshoe. And post-surgery, he developed a hematoma and a urine leak. So at the prostate was here. Now you sew the bladder onto your urethra, and it pulls apart a little bit because you get some bleeding around there. And you've got a urine leak. And then he developed what's called the bladder neck contracture. And there might be somebody in here, because about 7% of prostatectomies end up getting bladder neck contracture. That's some scar tissue. We tried to open it up, cutting, stretching, self-catheterizing. Eventually, I had to open him up and redo the anastomosis. That created incontinence, and then he went on to have an artificial sphincter. So again, every time I see this man, I think, wow, you've been through the worst of it, and you're still giving back. And quite an amazing story for people to continue volunteering in this world. Urology simplified. I'm going to let you know how easy my job actually is, because this is it. The bladder is a pump, and your urethra, penis, tube is an outlet, and that's it. So the problems that I'm going to talk about tonight are either a problem with the pump or a problem with the tube. And if I can make the tube stop leaking, I can make the man stop being wet. Now, obviously it's a little bit more complicated than that. And here's the penis, and here's the external sphincter, right? What I call the Yolanda muscle. If you've met Yolanda, one of the physios that we work with. This is the Yolanda muscle, the external sphincter, the one you can tighten, the one that you've been waiting all day for Sears to call, because they're gonna deliver that. And you think, God, I'm gonna go to the bathroom, and you start to pee, and your phone rings, and you've got to stop your flow, because you've got to get that phone, because Sears said they're coming. And that is the muscle. This muscle, the bladder neck, you can't, what's Sears? I hear that. Yeah, Sears Shaw, let's call it Shaw. Any of those people that you're always waiting on. Maybe your doctor even to call you back. No, the bladder neck is the muscle that we can't think about. It's intrinsic, it's internal. Just like I can't stand here and say, heart, beat. It's taken care of for me, luckily. And your bladder neck is taken care of. It sits here closed. But when we go and remove the prostate, this prostate bladder neck thing is removed, and you're relying entirely on the external sphincter, the muscle that you tighten when you are going to laugh, when you're going to lift, the pelvic floor, the Yolanda muscle. So before surgery, you have 2 valves. After surgery, you essentially have 1 valve or 1 sphincter. And that's where the rub is, because we can't look at a man at this time before surgery and say, I'm sorry, sir, you shouldn't have your prostate out, because when you only rely on the 1 valve, the external sphincter, it's not going to be good enough for you, because we don't have a way to differentiate between the 2. There's a little bit of talk that MRI beforehand might predict the length of a sphincter, but realistically, that's the thing. When Eric Hyman says to me, man, it went so well, can you see him because he's leaking? Or Dr. Gatto or Dr. Kozak, they did it the same way they always do it, and the man is leaking. Now, leakage happens for many reasons. So let's take a closer look at the 3 different types of leakage. Predominantly, we're going to talk about 1 type, but there are 3 types. So the first is called overflow. And that is basically your bladder is so full that you're leaking a bit all the time. Not a common situation, but it is potentially there. Urgency incontinence, twitchy, jumpy bladder. You got a sudden urge, you've got to make it to the toilet. And before you can get your pants down, you're starting to pee. A lot of the women in the audience will say, I've heard of that one. I know that one. I know where every washroom is, because when Mother Nature calls, I gotta go. And then stress incontinence. The one that we always think of with women after childbirth, basically a weakness in the pelvic floor. And that's the most common type that we'd think of after prostate surgery. So we'll deal with the least common, overflow. So with that one, the bladder is so full that you're losing a bit of urine all the time. Just kind of running out of you. It's as if you've got no control. It's like an overflowing toilet. Now, either the bladder isn't working, so the bladder has become overdistended and it no longer pumps, or there's a problem with the tube and it's blocked. So who gets that? Okay? It might be this guy. So he's had his bladder neck start to scar, right? There's been some scar tissue that's developed here. And the bladder's gotten slowly fuller and fuller. You're peeing less and less well, and the bladder's getting fuller and fuller. It's not common, but if the man says to me, you know, doc, I'm leaking day and night, so when I'm asleep at night, it's running out of me, I'm going to put the ultrasound probe on there and make sure that you are empty and well. Because overflow means you're not emptying the bladder. Not common, but it can happen, and this is why we're going to slide the scope in. And there's somebody here that I scoped, and he said I came up to him with both ends and said, which end do you want? And we'll come back to that. That does sound like me, so I know he's telling the truth, because that's something I'd say. But this is why I need to scope you, because I got to make sure your anatomy's okay, especially before we're going to do a device. So that's overflow. So who gets overflow? Not many men, but that man is full. He may not realize it because it's happened so slowly, and he's actually just leaking a little bit all the time. Never has a really good pee. It's just running out of him. And I don't want to miss that one, because that guy I can cure by getting his bladder drained. Teach him in and out catheter, get his bladder drained, and he sleeps through the night. He's dry. So that guy I don't want to miss. Overactive bladder. This may be what took you to the doctor in the first place, and PSA has a bit of a bad rap, and obviously you could debate PSA in this room, and that's not what we're going to do, because I'm on one side of it, and obviously the media might be on another side. But maybe you went to the doctor because you were getting up at night. Maybe you went to the doctor because your kid said, Dad, we can't take you to Lake Louise anymore because you got to stop the car every 1 hour. And it's driving them crazy. So you go to the doctor and he says, hey, Tom, when did you last have your PSA checked? I haven't seen you in a while. They check the PSA, they find it's elevated, you're off to the urologist, you got a biopsy, you got prostate cancer, you get a radical prostatectomy, and then it's, excuse me, I used to go pee a lot and I still pee a lot. I still got urgency, frequency, and I'm getting up at night. So I will ask you often, were you like this before your prostate cancer? Because overactive bladder, urgency frequency is in about 15% of the population, where you've got to go suddenly and you can't make it, and if you don't make it, you're going to actually wet yourself. That was existing before, but before you had a prostate, so you had an internal valve, you had an external valve, the Yolanda muscle, and you could probably hold back. Take away one of those valves and now you just have an external valve, and so when you got to go, and you may not make it. This is not the most common after prostate cancer, but it does go up when we radiate your pelvis. So your prostate's out, your PSA is rising, we give you radiation, and then your bladder is even more twitchy and jumpy, more urgent, more frequent, more nighttime pees. So I will spend some time figuring out whether a part of your leakage after is due to overactive bladder. Pretty simple, do you know where every washroom is? Do you get a sudden overwhelming urge that you can't make it to the washroom on time? Now, simple stuff can help a lot with this. Cutting back on your Tim Hortons. I mean, that's a big glass in the morning. Fluids, alcohol in the evening. And, everybody that comes to see me isn't like, I only have prostate cancer. It's, I had a heart attack at 52. I had prostate cancer at 62. I have a background with MS. I've got Parkinson's disease. And all of that stuff is important on how your urinary system works. Just as I'll say to you, hey, what's happening with your PSA since your prostate out? It's undetectable. Great. It's rising. They're thinking about radiation. Okay. Well, where are we at in that decision? You just had your prostate out and now you're considering radiation. So we're not going to get started on an artificial sphincter until that radiation is complete, because it's not the right time for it. So I want to know about those things. There's great medicines for urgency frequency, and in fact, even if I see you and you have had your prostate out, you've had radiation, and you're having urgency frequency, I'm going to try you on one of these medicines, and we've got many of them. And there's 2 different classes of drugs, and they're fabulous drugs. I don't see anybody in here today that I've tried Botox on, but Botox is another treatment that we do for urgency frequency. So it's not your typical leakage after, but there are many men that have such significant urgency, they can't find a washroom fast enough, and they are peeing themselves. The medicines didn't work, and I'm going to inject Botox into their bladder. How do I do that? I pass a scope, and up through the scope, I've got a needle. The needle comes out, and I put it right into the wall. One vial of Botox is $350. We're very fortunate in this province, in this city, that is covered for our patients. And it's been an unbelievable treatment. In fact, if somebody said, name the best things that happened in your urology career, Botox would be one of them. Artificial sphincter would be another one of them. Tension-free vaginal taper, bladder lifts for women is another one. So there are many great things that I get to participate in, and Botox is one of them. Again, in this room, if everybody in this room is incontinent, probably only 10 or 15% of you might end up getting Botox. And to be honest, 75% of those people would be women that end up getting Botox. Much less men get Botox. But that's why when we're sitting together in that room, I'm going to be asking you, are you emptying your bladder? Do you have urgency? When do you leak? Now, if you say, Doc, I only leak when I lift stuff. I only leak when I cough and sneeze. I only leak when I reach for the golf ball. Then we're talking about your classic stress incontinence. So male stress incontinence, after the prostate's removed, or radiation, I'm going to say the external sphincter is too weak to hold back the urine loss when you strain. So you do something to increase your abdominal pressure, lift a box, help somebody change a tire. There's an abdominal strain. That's transmitted onto the bladder. The bladder feels that pressure, and if the sphincter is not strong enough to overwhelm it, out it'll leak. And you could do Kegels till you're literally blue in the face, and it may or may not make a difference. And I don't mean don't do them, and I don't mean quit them, and I don't mean don't see Yolanda, because she's done some amazing work with some of my patients. But if you've spent your last cent on Yolanda, because it's not cheap seeing her, I recognize that. If you spent your last cent, honestly, you can say to Yolanda, Yolanda, can I see Dr. Baverstock to talk about these devices? And she's really good. She'll say yes, because if you're just not making the progress, let's not beat our heads against the wall. Now, when we sit down, and I keep saying when we're sitting down, and it's usually I'm sitting down with the husband, and then I'll say, is your wife here? Yeah, she's in the waiting room. Well, bring her in. Because the worst thing I want is for you to go out there and say, he didn't say much. When I talked to you, all I was doing was talking. So I said a lot. So I always say, bring your wife in, for sure. And I'm going to say, when does leakage occur? You're going to say, all the time, day and night. Oh, okay. So I'm going to say, are you emptying your bladder? You say, only with activity, only when I'm playing golf, doing work around the yard, coughing, sneezing. Okay, stress incontinence. With a sudden urge, I can't make it fast enough, Doc. As soon as I see that toilet, front door of the house, reaching for the doorknob, here in the water, helping my wife with dishes, boom, I gotta go. Remember, overactive bladder. So I want to know when the leakage mainly occurs. You may say all of them. And there are many guys that there are several types of leakage. I want to know what's happening with your prostate cancer. I want to know, hey, did anybody, since your prostate surgery, did they go back in and open you up, stretch your scar tissue? Did you have a catheter back in after your surgery? The bladder neck contracture, and then other stuff going on in your health. Because remember, what I do is quality of life-threatening. It's not life-threatening. That's the prostate cancer side of things. But I'm in the recovery mode. I'm in the quality of life business. So all the stuff that I do can wait if there's something more significant going on with your health. You may not want it to wait, but we sometimes have to make it wait. So things I want to know. How severe is your leakage? Right? What kind of pads are you wearing or diapers? Are you using the external catheter, a clamp, a condom catheter? You know, and many people will get to that stage where they say, I'm going back to a catheter. I'm putting on a condom catheter. How many times a day are you changing the pads? How many? And then, this is probably the most important. Why are you here? Does it bother you? Because you're going to be the guy going through this. Does this stop you from enjoying life? And did your wife send you? Because I had many a patient, they're only there because their wife sent them because she's tired of doing laundry. and I've got to see them for that. But it's the guy who's going to go through this procedure with me. Now, things I'll do, there it is, the cystoscope. And they used to say the definition of a cystoscope is a scope with a dink at both ends, the urologist and the penis. I think our reputation got a bit better since then, but there's the scope, and you don't want me to try put that end in. And I do need to look down with the scope because I'm going to offer you an $8,000 device. Again, covered, but I want to know the first time I look down your anatomy, I don't want it to be on the operating table because there are reasons we might have to back out. If I couldn't get the scope in or a catheter into your bladder to drain your bladder, I won't safely go ahead with the sphincter, which I'm going to talk about. So if you say, well, Dushinsky just scoped me, and I can get his note, and he scoped you, and he could get in, then I'm not going to re-scope you, right? I'm not desperate for cash, and I've got other people to scope. So tell me if somebody said, hey, I just had a scope, because if I can find that record, I'm going to do that. But I probably will make you, right now, used to be in our room at the Bladder Centre, but now they've moved it down to the South Health campus. This is called urodynamics. And is it necessary? And there are people in here that have been through urodynamics, I know. Well, urodynamics is an important part. Urodynamics, it basically means watching your pee flow. And what we're trying to do is, what's your bladder storage like? How well do you empty? What makes you leak? And we're trying to recreate that in an incredibly artificial setting with a nurse watching, hooked up to a computer with a tube in your bum and one in your penis. But we want to get some parameters on what your function is. Then, if your leakage is not that bad, we may say, you know what, I could make you way worse by doing one of my devices, and you are a panty liner per day and you catch a drop or two. And I know it drives you crazy, and I've seen those guys that, anything other than perfection is unacceptable to them. But I may say, you know what, I'm going to be the guy wielding the knife, and I think it's wrong for me to do it to you. So I may say, we're back to Yolanda, we're giving it more time. And we're fortunate to have Yolanda. There's other people in town. I just happen to know many of you have met Yolanda. She works at our center as well as the Prostate Cancer Center. And she also shares a record with me, so she can send me a note and say, hey, you got to see Gary, because he's just not making progress with me. Now, when I first started doing these talks, Mr. Rennick used to stand up and at the foothills and used to tell me that nobody needs what I'm going to talk about because everybody needs the dribble stop clamp. And I don't know if anybody's a clamp survivor. I've not taken this out and tried to put it on my penis. I have recommended it to a number of men in certain situations. And I've had 1 or 2 men in my 12 years that this is the answer for them. And so Mr. Rennick was kind enough to send these to us. And for some men, this is a non-surgical way to manage. And there were some guys that say, you know what, I'm not that bad at home. I just don't want to have an accident when my family takes me out to dinner. And so the dribble stop at dribblestop.com is one of the Cunningham clamps or clamp models that goes on the penis to try and prevent leakage. And these have not been used, although this bag looks well traveled, but these have not been used. And they have different settings, and it's really just a clamp to squeeze the urethra. And Mr. Rennick's, I think his son and daughter have taken over the company. They've moved it to British Columbia, but there's the 1-800. And I will print this sheet out often, give it to people and say, hey, why don't you try this while we're waiting for the sphincter, or give this a try. And it's a Calgary invention, actually, so it's kind of cool in that way. Now, the advanced male sling. So this brings us into the first of the surgical options for managing incontinence. And the advanced sling is actually for mild leakage. And so I don't actually put in as many advanced slings as I do, because remember, and you might be in this room saying 1 pad a day, You know, really? Why would that guy go for surgery? So leakage is a range, and the bother is a range. Some people would never come see a doctor about 1 pad a day. They just accept it. Others are very bothered by it. But the slings, the bladder lift or support of the urethra, is basically designed for people that leak a little bit. What are we trying to do with it? We're trying to basically support your external sphincter. Remember, the one muscle, the pelvic floor that you're trying to rely on, and the sling is essentially placed to try and, I'll say it, squish the urethra. I'm trying to increase the resistance in your pipe such that when you laugh, sneeze, run, jump, you don't leak as much. Now, it is a surgery though. So what would you expect? Well, you're gonna meet me, I'm gonna do a scope, I'm gonna rule out bladder infection. When you come to the OR, you can go to sleep or have a needle in the back. I give you antibiotics before, and there's a scrotum, incision under the scrotum and 2 pokes in the groin. All the stitches are dissolving, and then I'm gonna keep you one night and there'll be a catheter in. Now, it is a mesh product. This is polypropylene mesh. The same mesh you have for hernia, maybe for an umbilical hernia, groin hernia. It's the same mesh we use to support women's urethras. It's polypropylene mesh, been around a very long time. But essentially what I'm doing with it is I'm trying to squish or support the urethra. So it's an incision underneath, and I'm gonna lift the urethra. It's only for mild leakage, in my opinion. Now, I leave a catheter overnight. The next morning I take it out, and then I let you basically try and pee. About 20% of men will have trouble peeing that next day, and that's actually a good sign. And then I either put the catheter in for another week or so, or I teach you how to do self-catheter. It usually lasts about 1 to 2 weeks. Now, there aren't that many. I would say 1 man gets a sling for every 10 men that get an artificial sphincter. But it is still an option for guys that have mild leakage, but not guys, in my opinion, that have had radiation. Once you go home, I don't want you doing this. I don't want you squatting, because it can loosen the tape. So there's no squatting, lifting exercise for 4 to 6 weeks. People will have numbness under the scrotum. I bring you to the office. I get my nurse to call you just to make sure you are peeing okay. Because this one, really, I'm trying to control obstruction. I'm trying to block you up. I'm trying to block you such that you don't leak, but you can still pee, and it's a delicate balance. Why would you choose it? Again, it's for mild leakage. It works right away as opposed to the sphincter, which we have to wait 6 weeks to turn on. There's no pump to operate. It doesn't stop me from doing a sphincter later. And about 75% of people are cured or much better. Now, I don't like 75% because I think 25% of people are not where I want them to be. And I think we're still looking for a better product for mild leakage. I think we're still looking. So the gold standard is the artificial urinary sphincter. There's a reservoir, tubing, a pump that goes in the scrotum, and a cuff or control valve around the urethra. This is not brand new. It actually came out in 1972, same year I was born. The sphincter and me arrived. It is the gold standard. It's been around. There's been some changes, but overall the design is pretty similar. Now, to do this, you've got to have good hands, a good brain, and you've got to have a good bladder, which is where the urodynamics come in. I got to make sure you can hold a bit of urine. I got to make sure you can empty your bladder and that your flow is decent. And you've got to be incontinent for at least 6 months. So people will say, hey, just put it in when you take out my prostate. Well, first off, not everybody needs an $8,000 control valve. And secondly, we don't know what's going to happen after 6 months, or 1 year would be more typical. And the desire to be dry or nearly dry outweighs the fears. Are you going to take the chance? Like this guy. These guys are not so sure. This guy's going for it. Now, people say, oh, so my pee goes in there. No, that's a reservoir. This generates the little bit of pressure, which basically keeps the cuff inflated. You can see the pillowy cuff there. And that cuff is holding back the urine. So as you sit here, the cuff would be holding back the urine. Then when you say, hey, I'm going to go to the bathroom, you go to the bathroom, you give the little pump 2 squeezes, This is all implanted inside. This pump is in your scrotum, and it's squeeze, squeeze, have a pee. That opens up the cuff. You then get a chance to pee, and then within 60 to 90 seconds, the little pin moves back in, and it closes up. There's no battery, but it is still a mechanical device that can fail. What does it do? It basically creates this, open, closed. So it gives you another sphincter. It is the artificial urinary sphincter. It's a fabulous device. It's been around for a very long time. Now, you can imagine anybody that's had a hip or knee here, the doctor will talk about infection, infection, infection. And these devices do not do well if they get infection. So at the time of surgery, we're going to rule out infection beforehand and treat it. We're going to make sure that you're not blocked up. Again, you can go to sleep or be awake for it. I don't keep a catheter overnight. And then I actually spend 10 minutes scrubbing your perineum and your genitals once you're asleep. And because infection is a disaster. And every time I spend 10 minutes scrubbing somebody's genitals while they're asleep, I always say to the people in the room, I say, you know, my mom is so proud of me of being a doctor. She's telling all of her friends about her surgeon son, and here's me scrubbing some guy's balls for 10 minutes. But it's not worth my while or yours to get infection. I get basically one shot to really try and do it right, and that's the first time is the best. Now there is a surgery picture coming up, and I just want to show you that we're going around the urethra. This is your P tube, and I'm going to go around the urethra and place a cuff around that. And when it comes to the penile prosthesis, people will say, oh, put in a big one for me, doc. But no, I put in what I measure, and measuring for cuff size is critical. So these come in a package, and you know, this is 4 centimeters, there's 4.5 centimeters, and what I'm measuring is how tight it'll be. I want it to be snug, but I don't want it to be like a vice grip, because a vice grip will erode. It'll work its way through the delicate body part that we have. So I want it to be tight enough, but not too tight. And so they come in different sizes. 4 centimeters, 4.5 centimeters would be the most typical. And that's the cuff here. That's what I'm going to measure around there. Now, the bummer about this device is you go home with surgical pain, still leaking, and maybe other problems, swollen scrotum, can't go poo, and you got to wait 6 weeks before we activate it because we can't start squeezing this until it's healed in a bit. There's 2 incisions. I make one underneath the scrotum, and then I make one for the reservoir up like a hernia incision. And swelling and bruising is pretty common. Does it work? Absolutely. 90% of male patients love it. When we looked at our own group, the majority of patients would have it done again or recommend it to a friend. And I think it's probably one of the most amazing devices that still exists in the world that I practice. Now, if it gets infected, it's coming out. We're waiting 3 months and then putting another one back in. And I will say there's lots of guys that have put these in. I've been around for 12 years, so you get a mechanical failure, you get a tubing problem, and uniformly the guy wants to see me that same day and say, when are we going to put a new one in? Now, it's Canada. It doesn't happen the next day, but I am going to see you to make sure what's the problem and how are we going to fix it. So these are fabulous devices, and I hope they're around for as long as I would practice medicine. And that's what this guy had. So back to this guy, he had an artificial sphincter, but read in that letter, he had a bladder neck contracture, the scar tissue. I had to open him up. I had to get him to stay open, and then he got an artificial sphincter. And it wasn't an easy road because he got some pain and swelling, but it was worth it in the end. This is probably the key here. If we get infection or erosion, it's got to come out. And once we take it out, depending on your health, we may or may not be putting one back in. And that's where things like medical alert bracelets become important. Or at least the ability that other people around you know what you've got, because medical alert obviously costs some money, so some people can't afford that. But it's just important because let's say I do a sphincter, you're so delighted by it, but you have something in your liver and they're going to do a surgery, and when you go to sleep they put a catheter in. So you take your delicate urethra, put a catheter in with my cuff around it, and you'll get an erosion. And I'll spend a lot of time talking to you about, don't let anybody put in a catheter, and let me turn the device off, and then you can have a catheter. But I love this device, and I've got a couple of them here, and I want to leave with 2 of them, so I'll pass one around. You can just have a look at it as I'm talking about it. These ones are not working models as much because they don't have any. These would typically have saline in them. They're obviously not, they're not really functioning right now, but you'll get a sense. And do I really put all that much stuff in there? No, I trim the tubing to fit. So there's not going to be all this stuff, and it's not hanging out of you, it's all inside of you. So it's pretty darn amazing. And we're pretty fortunate to have them. So in fact, we're going to move on to talk about surgical options for erectile dysfunction, but I will pause for a moment just in case, before I leave leakage, if anybody has any questions that we'll talk about for leakage. And if you're shy, you can always come up and see me after. We have one of my long-standing patients here, and he was kind enough to say he's willing to talk to other people. And it took me a while to convince him to get a device, but I did put one in, and he is living with a device, and he's been kind enough to be a volunteer if people want to chat about their devices.
What's the lifespan of one of these?
You know, and I probably tell every patient a slightly different number. I'm going to be back there doing some type of warranty work, changing a pump, correcting a tubing problem, about 20% of the time within 10 years. So 1 in 5 guys are going back to the OR, but those guys are usually like, can it be tomorrow? And sometimes simple stuff needs to be done. It's been a problem in the tubing, and there's a hole in the tubing, and I can fix it. Sometimes everything's got to come out. It's infection or erosion, but it's about 1 in 5 that I'm doing something again within 10 years. And so it's Gore-Tex and silicone, titanium pins put into the body, and it's a finicky little device that's going in, but it's actually stood the test of time pretty well.
You didn't talk very much about the exercises you do after you have a prostate out, the Kegel exercises. I mean, that was drilled onto me that you have to do this 10 times a day, sitting in a car. You do it for week after week after week, as often as you possibly can.
Yeah.
Very successful with me. I don't have any leak.
Yeah. No, and
it's so important, and you didn't dwell on it.
Right. Because obviously my topic tonight is surgical therapies for. So the 90% of people that will never meet me to talk about these devices is going to be successful with what you were successful with. And the Prostate Cancer Centre, through a donor, was kind enough to find a way to offer 2 Yolanda sessions for each patient within one of their programs, because it is so important. I'll put it on tape. It is so important that you see Yolanda, you do your Kegels, every time there's a red light, do them. And absolutely 90% of men will never need to meet me about this. But when Kelly said, can you come and talk? And I usually talk about the surgeries that I do because I'm a surgeon. And so for the 10% of people, which you're not part of, this is the end of the line. And so if you've done your muscle training, you've done your Kegels, and still you're not dry and you're so frustrated, then that's the guy that I'm going to see and offer these surgeries. But you are so right in that the majority of men, time, Kegels, Yolanda, physio will make a difference. You're absolutely right. Anybody else? A question?
What is Yolanda?
What is Yolanda? What is a Yolanda? Because she's almost a proper noun. So Yolanda Liu is a pelvic floor physiotherapist that we've had in Calgary for my whole career of 12 years. And she's pretty much the same age as me. She's in her early 40s. And she's a pelvic floor physiotherapist that really specializes in men and pelvic floor physio. So the things we use her for are post-prostate cancer leakage, pelvic pain, and she really almost sees exclusively men. And so her name's Yolanda Liu, and she works with us at our center as well as the prostate center. She used to be at Southland. So many people have met Yolanda, and they even know the Yolanda muscle joke that I talk about. Anything else to do with?
The other thing is you can start this exercise 2 or 3 weeks before you have surgery.
Yes.
I mean, and I never saw this lady. I mean, you just read the pamphlets, you talk, people tell you at the hospital, you just do it. And you just have to.
No, you do.
Possible moment of the day that you can do it. Sitting in the car driving is a great place to do it.
And I think you're right. Starting it before the surgery is absolutely appropriate. Now, it's funny, as a surgeon, you wish people would quit smoking, exercise, lose weight before they come for any of my surgeries. So, which is, I take out people's bladders for bladder cancer due to smoking, and they continue to smoke continuously throughout. So you raise a great point. Coming prepared to surgery, starting the muscles beforehand is the absolute right thing to do. And now you did well with obviously reading the pamphlets. I've had other patients that one session with Yolanda, they went from 4 pads to 1 because what they interpreted is that they needed to tighten their abdominal muscles, but they weren't tightening their pelvic floor, and so they were pushing out their urine. Wrong, absolutely. But I was the surgeon. I'm like, you're 4 pads a day. I'm the world's worst surgeon. One session with Yolanda, and he was a pad a day. And so I think if you can read the pamphlets, do it properly, get benefit, great. If not, the pelvic floor physio. And then I'm only talking for surgery for the people that don't get that win. Anybody else here before? So now this is obviously even a smaller group than the 10% that will ever end up getting to this. Because the majority of men that have erection troubles after prostate cancer, the majority of men are going to give up and say, well, you know, I wasn't having good erections before, it's not a priority for me and my partner, or, you know, I'll take the pills and then that's it, I'm going to stay there. That's as far as I go. Some people will go to vacuum erection devices. Some people will learn injection teaching from myself, my nurse, or Dr. Lee. Urethral suppositories have sort of come and gone, expensive and painful. And so these were the standard ways of managing erections. But for a very slim group, there are penile prostheses. This is not outside the body. It's not a strap-on. It's not something you buy at a sex shop and wear. It's something that I surgically install. Now, it's a long-term solution that is spontaneous. A lot of people will complain, hey, I want to have an erection. Where's my needle? Go to the fridge. Stay there, honey. Be in the mood, because I'm just going to go put this needle in my penis and sit there for 15 minutes, scared to put the needle in the penis. And I gave myself a vaccine once, and my wife, bang, my child, bang, and me, whew, this is going to hurt. And so then every time I'm like that, I'm like, wait a minute. So my hat's off to anybody that's willing to put a needle in their penis to bring on an erection. I think you deserve an award for that. Now you do get a reward, not an award, a reward for it. Now, the implants are, again, for a tiny amount. How many men in Calgary got one of these devices last year? 8. How many men should have got them in Calgary last year? 20 to 25. So that's why it's important that I come and talk to groups, and because there are some men that are absolutely devastated by losing their erections and how important it was to their life beforehand. And they were devastated by it. And I just want this message to be out there that there is an option for the men that fail needles and injections and pills. That you should at least talk to me about it. There's no ongoing cost for the pills, and remarkably, I don't know if it'll always stay in Alberta, but this stuff is covered again. Now, how far are you willing to go to get an erection? Is an erection that important to you? Are you willing to have surgery to achieve it? And that means Hi, sir, what are you here for today? Oh, shoot, I didn't think of that. I'm here to get an erection back, right? Because you're going to come in the hospital and people are going to ask. Or the man that's from Lethbridge that drives up and stays with his daughter's friend who's kind enough to house him overnight. What are you up here for? Oh, I didn't think of that. Sports hernia? Like, you got to come up with a game plan here. Are you willing to have surgery to achieve it? Are you prepared for the risks of infection, erosion, and need for revision, right? I'm putting Gore-Tex and silicone and a device into a man, and there are risks about it. And do you have a willing partner? Now, you might not have a willing partner now, but you plan to get back into the game. And I don't adamantly require that you have a partner. Who are you going to use this thing on? It's not a gun registry. But if you tell me, you know what, my wife's in the waiting room, and I say, bring her in, oh, she's too shy, or she never wants to have sex with me, then I'll be like, well, who are you planning on using this with? Because I want to know if there is another important person in your life. Now, where does this go? Because everybody says, Doc, put in the big one for me. It goes inside the penis here. I've got to open you up underneath and create a space such that I can get these cylinders inside. And the final surgery picture tonight, not to shock you, but this is what I do. I make an incision and then I use some metal sounds, we call them, to dilate or stretch. There's no going back. So I'll tell the men, if tomorrow Super Viagra comes out, we're out of that because we've got this in there. So there are risks: infection, erosion, revision. Other things, diabetes, radiation, nerve issues are important to me, stroke. Have you exhausted the other options? Because there is no going back. Now, you'll say, what the heck? Do people really get this? You might be thinking that. Then you might also be thinking, I'm a taxpayer. Wait a minute, I'm paying for this? And thank you if you are thinking that, because I've often thought, wow, we are very fortunate to live in a place where we will pay for a man to get his erections back. Now, granted that you're a prostate cancer survivor, you've paid a terrific price for having prostate cancer, and that's why it is offered for people. So, this is only one of the two cylinders, and now everybody again is looking, whoa, do you have a smaller size? But remember, the majority of your penis is actually inside your body, so you can comfortably go around telling people that you are 6 inches, because the majority of it is actually inside. So I put 2 of these cylinders in, and they do come in different sizes, and I can make them longer with rear tip extenders. And I have put in a very long one, special order from Jamaica, but it came. And they do come, but the majority of men come in a certain size, and then I can make them a different size as needed. But everybody will ask me to put a longer one in, and I can't. I size it because too long a device and we get into erosion. Actually, I've got a couple here I'll pass around. Now this one, I'm going to show you, actually has the pump within the scrotum, just to show you that you can hide something like that in there. And then just a couple. And you'll say, wow, all that stuff. And again, the tubing is longer, and I can bury this stuff inside of people quite nicely. Now, this is the gold standard, and it's a 3-piece inflatable penile prosthesis. Now, what are the 3 pieces? Because there's actually 4 pieces. So the one piece is the reservoir that holds 100 cc's of fluid. One piece is the pump, and then one piece is made up of the 2 cylinders. It's totally hidden. It actually acts and feels like a normal erection. We call this the LGX, length, girth, and X to sound cool, LGX. The length and girth, though, I'll warn you, it is not going to be as long, it is not going to be as wide as you want, but it will be very hard. So cover your eyes if you haven't seen a penis, I apologize. But it basically goes down and then up. It doesn't get a lot longer, it doesn't get a lot wider, but it really does get very, very firm and very, very hard. and it's totally adequate for everything you might need it for. Now, there's a couple different models. There is the simplest penile prosthesis called the malleable rod. Now, in Lethbridge, for example, this one is covered, and the one I'm passing around, you'd have to pay the difference. So we have different politics in different provinces and different parts of provinces and different parts of Canada, and in Calgary, both are actually covered. That's my preferred approach, because this one, you have an erection look all the time. So 2 of these cylinders sitting inside of your penis, and you have an erection all the time. You can actually bend it down and bend it up. But straight on, inside the casing of your penis, this is firm enough for penetration. And that's the simplest. I don't put in many of these, but I do put in the pump that you're passing around. Nothing really to fail. Now, why is it yellow? And this is actually really cool. If you said what's one of the coolest things that's changed with these devices, this yellow coating is antibiotic. So it's minocycline and rifampin, 2 antibiotics that leach off the device once we implant it to minimize the risk of infection. And that's really helped. And we have that on the artificial sphincter as well as on this. So I put it in yellow, but if I had to take it out, it would be white because that antibiotic coating has come off. Again, cystoscopy. I don't want to find out for the first time that you've got a blockage in your urinary passageway, because I need a catheter in to be careful of your urethra. Here, what are you going to tell people you're having done? Because it's going to be at Rocky View, and it's going to be a penile prosthesis. Spine or general anesthetic is fine. And then again, the 10-minute genital scrub that my mom's so proud of. What to expect after surgery? Well, you're going to have a swollen scrotum. You're going to have bruising, because it's a lot, if you can imagine, to get that in through a small incision in the scrotum. I really have to dilate the spaces. And the penis is very vascular. It's got a great blood supply. I'm going to keep you overnight, antibiotics, look for bruising and pain. You're not going to touch this thing for 3 weeks, 4 weeks, even up to 6 weeks. And on the internet, people talk, oh, I have my patient cycling it right away. Oh, my goodness, I don't know. I haven't found a man that can touch this thing until I see them at 4 weeks and say, here it is, this is how it works. And they'll say, oh, that's awfully sore. And so it's going to be a bit of a learning curve. Again, we don't like catheters in that go down the urethra tube when I've got this hardware around it. It's not quite as desperate with this one as it is with the cuff, but just if you've got one of these devices, just know that a catheter is potentially a risk. Now here, very reliable. I always put this picture of me walking up the 18th hole at St. Andrews, and I put there, would I get one? An artificial sphincter, I would get. I suppose if I was sitting in this room and listening to me talk about something that could get my erections back, and if that was important to me at that point in my life, and my wife, and she said, you know, go for this, then it's a great option. I just want you to plant that in your brain and say there is an option. Or maybe you have a friend that's new to prostate, and you know, you tell them there is an answer. And again, I think about 20 of these should go in a year in Calgary, so we are a city of 1.3 million. It's not as if we're going to be handing them out, but there are some men that would benefit, and I want to meet them. Now, we're going to stop there, then we'll do questions. If you want to meet me, your urologist, your oncologist, your radiation oncologist, your family doctor can send me a referral, and then that's the way we work in Canada. I will see you, we'll talk about the devices, and then figure out whether you're the right guy for it, what are your priorities, and where do we go from there. So, pleasure coming, thank you for the work you do, and David, come on up.
Thank you. Thank you, Richard. I think if we had a category for outstanding presenter, I think this gentleman would definitely be a candidate. And thank you very much for the suggestion.
Thank you. Wow.
When you put in that implant, do you take out the vascular tissue?
So to put in the penile prosthesis, yeah, I have to basically dilate. Dilate is our doctor word for destroy. So I have to stretch what's called the sponge tissue, and the sponge tissue is the spongiosum is the vascular tissue, and I go next size please nurse, next size please, next size, up to the point where basically there is just the corporal body or the shell that would normally fill, and that's why there's no going back. And so if Super Viagra comes out, and we're not about to have that I know of, it won't work, and because there is no turning back from this.
Why is there penile shortening after radical prostatectomy?
Yeah, you know, hot topic. So there is, if you think of it, there was a prostate. It was 2 centimeters, 4 centimeters, 5 centimeters, 3, whatever it was. And then we must bridge this gap. So you've pulled the bladder down and elongated the neck of the bladder, but you've also pulled the urethra up. So there's a shortening that comes with that. There is then, you have a catheter in for 2 weeks. And we know that that period of time with the catheter in might put you at risk of things like curvature to the penis, Peyronie's disease, plaques. But it may also cause some scarring in the urethra that we don't quite understand. Then the other thing, of course, is prostate cancer. Prostatectomy is such a damaging thing to the erections that you're not getting the tone increase, decrease, which you get with cycling of erections, where you can look a little bit fuller because you basically end up flat all the time. And of course, then your penis looks shorter. So there's a number of factors. Yeah. But it's probably one of the great unanswered questions of life.
Those are my questions. Any questions, please? Go ahead.
Doctor, you didn't touch at all at the suprapubic procedure.
So suprapubic catheter. Yeah. So I actually didn't talk, likewise when I didn't talk about physio as much, I didn't talk about, you know, just the bailout, which is let's go to a condom catheter or an indwelling catheter or a suprapubic catheter. So part of my job is treating people that have leakage, basically the urine is running out of them. But another part of my job is managing strictures and blockage. So you might meet me because in actual fact you get blocked up. And it might be scarring from radiation, it might be scarring from surgery, it might be another injury that you've had, and you develop scar tissue in your passageway. And when I said that my job is to make sure the bladder pumps and the tube is open, if I can't get your bladder neck open, and I get you open, I cut the scar tissue, and then I teach you how to pass a catheter in, drain the bladder, take it out. But if we lose that access, you know, and you're no longer open, the urine can't get out, you have to drain it somehow. And so a suprapubic tube, which you're speaking about, is potentially something that people may have had if they had cryotherapy with Dr. Donnelly in this room. They may have had a suprapubic tube temporarily, and that is a drainage tube that goes directly into the bladder, 2 fingers above the pubic bone. And for some people, indwelling catheters becomes the most appropriate way for managing their bladder. It's a new set of problems. Tubes get dislodged, tubes plug up, you know, tubes fall out at the most inappropriate time, you know, travel when the doctor's office is closed. But indwelling catheters, suprapubic tubes are all basically great bailout ways that we have, because we've got to get the pee out. And that's a good point. Thank you for that. Anybody else have any questions? No, once again, thank you for having me. I don't know if it's my 5th time, 6th time, or 4th time. I have lost track, but I always welcome the invitation. It's a nice opportunity for me.
Thank you, Gavin.
Yeah.